Good morning, good evening, good afternoon, depending on which part of the world you're at. It's me again. My name is Dhruv Sahai. I serve as the Chief Operating Officer at Kapil and welcome everyone to episode 67 of Unboxing AI. Unboxing AI is our way of introducing our viewers to our partners, to our friends, to our customers, and speak more about radiology AI. It's an initiative by Carpal, and for those of you who do not know Carpal, well, Carpal is the world's largest platform and marketplace that is enabling the effective adoption of imaging AI by connecting radiologists the world over with the best AI solutions out there, with just one mission, making healthcare accessible to all. With that in mind, I would like to introduce you to our guest for today, Dr. Benjamin Bender from AIRAmed. Dr. Professor Bender has studied human medicine at Eberhard Karlas University of Tübingen. Since 2008, he's been undergoing specialist training in the Department of Radiology at the University Hospital. In 2006, he became a senior physician in the Department of Diagnostic and Interventional Radiology. And since 2019, he has been serving as the CTO of IRAMED. As of 2025, he is additionally deputy medical director at the University Hospital Tübingen. Lot of accolades. I mean, over to you, Dr. Benjamin. Why don't you tell us about this impressive career journey that you've had and why you do what you choose to do?
Hi, and I'm really thank you for having me here. It's an honor and a pleasure to talk with you. Well, my journey began probably way before I started studying medicine. I always had an interest in software and informatics. I already started creating programs as a pupil and already earned some money as a student creating software for some friends and their companies. And before studying medicine, I actually thought about studying informatics and worked at IBM for a couple of months as a working student and quickly decided that the more interesting jobs there are not performed by the people who studied informatics, but more generalized uh, topics like biology or physics or medicine. And that's the reason I started with studying human medicine. And quickly during my doctoral thesis, I found out that the radiology has the option to have both worlds, working with imaging data, creating on algorithms, and also caring for people. And during my time as a radiologist, I did a lot of work with VBM, voxel-based morphometry, on different kind of disease. And together with Tobias Lindig, who is the co-founder of AIRAmed, we quickly identified that there are some commercially available suits out there in 2000 and I think it was 15 or 16, but we weren't really happy with the results they had. And that was the time where we decided we believe that we can do it better. And then we started to find out what kind of regulatory stuff do we have to adhere to, and what kind of rules do we need to follow. And it became quickly obvious that in a vehicle like a university hospital, it would be really complicated to get this done and to get a CE certification to actually use a product we might have on patients. And this is a typical problem of today's research. We have a lot of good tools out there, but only a few are able to make the step from the workbench to the actual patients, because we're not allowed to use software that we created on our own here in a university setting. So we have to prove it's working on a wide variety of data sets. You have to make sure that data protection and data security are adhered to. And this makes things really complicated. And that's why we decided to found AIRAmed. Yeah, for the last 7 years now, we've been working on this topic. And I think just now that the brain volumetry, that's what we do, becomes really interesting due to these new therapeutic options in Alzheimer's disease, and where we really see suddenly a need. We see patients coming to us and asking, hey, do I have Alzheimer? I'm not sure. My memory, I think there's some kind of memory decline. I'm not really sure. Neuropsychologist testing is still not pathologic, but I feel there's something wrong. And in these patients, what you do is you do a brain MR. Is there something pathologic? And I think their brain volumetry can really help to make more informed decisions and to guide these patients.
No, absolutely.
Because
You're making tremendous, progress in terms of early detection of Alzheimer's, and I would definitely, like you to speak more about all the work that's going in, and any unique cases that you would like to talk about.
sure. Well, what is the typical problem we as radiologists face? So we see lots of images, and there's a wide variety of normal aging. And if you ask two radiologists, you probably get three different opinions. Is it atrophic? Is it not atrophic? Is there an area which is suspicious or not? Is it normal? And in the end, you don't want to frighten patients because it's a very serious disease in the end. So in the end, you say, well, might be a little bit atrophic, but if you still have only a feeling something is wrong, it's probably not something. And then patients really don't know what to do with this information. So you are in a need of some kind of to objectify your feeling as a radiologist. And their quantitative results you get from a volumetry can really help you in guiding your report, because we know from larger cohort studies very well in which areas we have to look at. For example, the classical Alzheimer usually starts way before they become clinical evident with a positive PET scan. But you cannot just put everybody into a PET scanner. Even though we know 10, 20 years before they will convert to Alzheimer's disease, they will have a pathologic amyloid PET. But it's just not an option to do this with every patient out there. So you have to see that we need something else. And 2 to 3 to 4 years before they will convert to Alzheimer, you see neurodegeneration, which starts. And MR is really capable of identifying neurodegeneration, because in these patients, you will see a volume decline in typical areas. And in the classical Alzheimer's, these typical areas are, for example, the hippocampus, the temporal lobe, and at later stages, parietal and the frontal lobe. And so if you look back into literature, there has been suggestions to use the hippocampus as an early sign. And this works very well in large cohorts. But you have to be aware, hippocampal volume shrinkage is not something that is 100% specific to Alzheimer's disease. There are other diseases out there that will also cause a volume decline in the hippocampus. You will see it in any patient with a normal pressure hydrocephalus, for example. You can see it as a result of an autoimmune encephalitis. You can see it in patients that have a mild cognitive impairment but will stay stable. They also have a reduced volume of the hippocampus, and some people have smaller volumes than others. So the hippocampus volume alone is a good hint, but it's not the only hint. So you really have to look for patterns. And for example, what we do in a clinical routine is we look at these patterns with volumetry, because we're looking at patients that do not fulfill the clinical criteria for dementia. So they're not Alzheimer's disease patients, because in this stage, you really don't need the MR anymore. Then the disease is already known. So these are patients at a stage of subjective cognitive decline or mild cognitive decline. And you have to make a decision, will this patient likely convert to Alzheimer or not, to give them an informed information, to guide them what steps to take next. And we had, for example, a lady here in their late 50s who said, well, something is wrong. I start to forget things. I already went to a neurologist. He did some tests and said, well, everything is okay. Don't be worried. I'm still worried. And I've heard you have this volumetry. Can you help me? Can you do this volumetry? And we said, yes, we can do, but you have to know it's just one piece of a puzzle. We cannot make a diagnosis with this, but we can see, are there any areas where your brain volume is below what we expect for the age you are. So we performed a normal MRI with a 3D data set, did our volumetric results, which takes about 2 to 3 minutes, and looked at the results. And what we saw was that all of the brain areas were just right in the middle of where we expect them to be, with 2 exemptions. One was the hippocampus, which was just at the border of being slightly pathologic, 2 standard deviations from what we expect for the age on both sides. If you looked at the images, well, I asked 3 radiologists and all of them said it's okay. If you looked really closely, you could say that the temporal pole was just a little bit enlarged, but that was the only sign you really could see. But this is still unspecific, as I said. And then what we also saw, that the gray matter volume of the temporal lobe on the more affected right side was also just in between all the other areas and this hippocampal volume. So we had a pattern where the volume of the hippocampus was much smaller than the rest of the brain. The temporal lobe was smaller than the rest of the brain, but a little bit larger than the hippocampus, and the rest of the brain volumes were normal. And this is a typical pattern we see in a classical Alzheimer's disease, where you have the disease spreading from the hippocampus over the temporal lobe, and the next step would be the parietal lobe. So we said to this patient, well, there is a high risk that you are an early Alzheimer case, and we would suggest that you contact a memory clinic, that they do a more thorough examination, and they also do lumbar puncture to see if you have amyloid pathology. And in this case, it was confirmed, and we just saw this lady a little bit later, 1 or 2 years after this initial visit, and then the pattern was clearly seen, and she was already at an early Alzheimer's stage. So yes, this was a confirmed case. And she said, well, it was good for her to know early because she could adapt to it. She could talk with her family how she would like it, everything to happen and what to expect in the next 5 years. It helped them to have a diagnosis and to know what to expect, and to not be in this kind of void where you have no information and you have a feeling something is wrong. And I think we as doctors should really try to guide patients. And I think volumetry can help in these early cases. And now, a couple of years later, we are at the next step. Now we have some possible therapies. We still don't know if they work on a long outcome, but we saw that these amyloid removing therapies can slow down the progression. And in my opinion, if we start to treat these patients earlier in the disease course, not in an early Alzheimer's stage, but in the MCI stage, or even a little bit earlier, we might be able to get even more impressive clinical results. Because what we know from larger cohort studies like the ATNI Collective is that just 2 to 3 years before patients become symptomatic of Alzheimer's disease, the neurodegeneration in the hippocampus of these patients is at its highest rate. And at the time of the clinical conversion, the hippocampus is already gone. The atrophy rates start to slow down. And I think we are at this stage too late to protect them with an anti-amyloid therapy. This is just an opinion. There's no clinical data out yet that supports this. But from a pathophysiological approach and from the evidence we have from cohort studies, this is highly likely to happen like this. And this is the reason why people start to ask for these kind of diagnostic tools. And I think in these kind of diseases, it can be really helpful. And yes, Alzheimer's disease is the most common dementia, but there are also others. Sometimes you have a frontotemporal dementia, and these therapies won't work, but these usually show other patterns. So you need to be aware of the common patterns, but also the uncommon patterns. And you already need to know that there are some mixing and there are some complicated cases. So there is an FTD variant of Alzheimer's disease. You will never reach 100%, but I think this is just like everywhere in medicine. We will probably never reach 100% in any disease unless we ask the pathologist.
No, I mean that's extremely informative, Benjamin. And sorry, viewers who are listening in, please feel free to post your questions on the Q&A box. I already see we have quite a few questions. We'll try and take as many as we can as time permits. Let's start with the first one. It's by an anonymous poster. Benjamin, they ask, what do people typically get wrong or misunderstand about Alzheimer's?
What they typically get wrong about Alzheimer's, I think, well, it's a devastating disease, and I think most people are afraid of it. Yes, they are. But I think doctors are in my opinion, doctors are sometimes afraid of making a diagnosis if they're not 100% sure. And in the end, from my experience with patients, every patient knows that any diagnosis is not 100%, but they are really eager to be able to take their own future in their own hands. They want to be able to decide on their own, and they don't just want to wait and say, well, we have to wait. And so you need to take all the evidence that you have, and you have to name it and say, well, this is not 100% yet, but there is a high chance, and you need to talk about this. And I think most problems arise from doctors who are afraid of telling the truth because they might think patients cannot handle it. And I think this is something that's not correct. And if you look at, for example, Alzheimer's initiative in the US has asked patients, and most of these patients said they would have liked to know more earlier their diagnosis, because then they have time to adapt and to talk with their relatives about it and to take precautions, what to do next, and then that they have more time and live their life differently. And I think that is something that people need to know and need to take into their mind when talking with these patients. I'm not saying you should tell any patient who has a hippocampal atrophy that they will have Alzheimer's. This is definitely not true. And everybody needs to be careful when they use volumetric tools, because technical failures are possible. So you actually need to look at the images. We still need a radiologist who has a look at the image. Are there artifacts in the image? Are there normal variants that might explain a pattern? So not every pattern is pathologic. Sometimes it's just a variant, and you look at images and say, yes, this is just a normal variant. The segmentation is correct, but the pattern is explained differently. Or you see that there is, for example, susceptibility artifacts from metal implants, and you say, well, the frontal lobe we just cannot evaluate because the images itself doesn't contain the information we need. And if you do all these steps, then it's a powerful tool. If you just use it as a tool and say, well, it says, and you don't look at the images anymore, then it will not work in my experience.
No, absolutely. I agree with you 100%, Benjamin. And, interestingly, like you said, that, patients, well, people today want to be aware of what's going on at an early stage, because I think preventive healthcare is the way to go. And interestingly, Chavi, who's our colleague at Kapil, asks a question which goes straight down this line. She asks that, patients take matters in their own hands and get many investigations done to see their results. Do you envision a future where volumetric MRI reports become part of patient-facing portals? And if yes, how do we balance transparency and misinterpretation?
It's a very good question.
Yeah.
It's something we've been talking internally about also a lot lately, because at least in Germany, it's really hard to get compensation for these kind of examinations, and patients are actually willing to pay. On the other hand, if you have a potential diagnosis, the patient needs to know which are the next steps to take. And to be honest, the volumetric results is just the neurodegeneration part. And you cannot make a diagnosis solely based on the MR. So you need the clinics, you need the lab tests, you might even need a follow-up. So I think, yes, patient-facing portals are something we need because patients will ask for it. But I think, at least for now, or at the stage we are now, we some kind of need to include expert guidance in these kind of portals. So I don't think it's a good thing to have patients upload their scans and get the results without any guidance 2 minutes later, because then we are at the same step where we was before. The patient has an information, doesn't know how to interpret it, and will ask ChatGPT or whoever, and will get an answer, and then we're at the same step. They don't know what to do. So I think if you have a patient portal, you need to have some kind of neurologists, psychologists there that will, or radiologists that will have a look at the results and offer some advice on the next steps to take with these results. I always suggest our customers to take the reports, print them out, show them to the patients, because I think it really helps to visualize what you're talking about and why you believe something is normal, or why you believe someone has a high risk that something might be abnormal. But I don't think you should currently leave patients with this kind of information on their own.
No, absolutely. I think awareness is a great thing. Self-diagnosis is a dangerous thing. And I think we need to be very wary of that. So great. I'm
Well,
going to take some more questions. There's a whole bunch of questions here. The next one, and I think this ties on to when you were saying that, we're not 100% there. But I mean, we are always building towards it. The next question, it's an anonymous attendee, is what are the findings that you are planning or exploring to get into the future?
also a good question. Well, we have a lot of things we are planning. Some are more going to be implemented earlier and others later. So the next thing we will implement, for example, is a longitudinal evaluation. There are some other competitors out there that already have this, but I think one thing in a longitudinal comparison where you need to look at, and which makes it really hard, is that if you measure a single subject twice, you will never get the exact same results because the patient is not lying in the exact same position. The magnetic field is not 100% homogeneous, and then you will get slightly different results. And if you measure someone twice, you really need to be able to say, is a change you measure, is this just by technical change explained, or is this a true biological change? And what we currently try to develop is a way where we can help people to identify, is a change we see over time a true change, or is it just by technical reasons? And if you see that someone is moving out of a horizontal set value. So what we report is set values. So these are standard deviation, how far someone is off from the standard deviation compared to an age and gender matched reference population. And anybody can be below or high, this is normal, but as long as they stay at the same set level, it's okay. And if they move out of this area, for gray matter volume, it's becoming lower, for ventricles, it's becoming higher, then you would say this is increased atrophy rate or an increased volume. And that's the step where you can say this is probably atrophy. Before, you should be careful with the word atrophy. And this is something I really think is important to look, how confident can you be that the change you detected is an actual biological change and not. And that's something we've spent now some time in and trying to develop a method to help people identify this, and something we will have in our next release, for example. Something which is more in the future we are also working on is in guiding in the atrophy patterns. This is more complicated because data out there for this kind of approach for a classical Alzheimer, we have enough data, but there are rarer variants like posterior cortical atrophy, and also you need to include FTD patients. You have a lot of behavioral variant FTD patients out there, but for example, semantic dementia patients are less good to get at, and we need a lot of data to get a good product here. And that's something we are currently, for example, working on, but where I don't know how long it will take, because when we finish with a product, we want to be sure that it actually helps people, and we cannot just work with 80% of the data out there.
Yes, okay, I'm going to move on to the next question now. It's from Shrikant. He says, with recent advancements such as Philips launching software solutions for Alzheimer's across both 1.5T and 3T MRI systems, what are the main technical hurdles in ensuring that AI models and imaging biomarkers for Alzheimer's disease remains consistent and reliable across different field strengths and scanner platforms?
This is also something which is actually is a problem, and people try to solve this by, for example, going for relaximetry or for example, using an MP2 range and not working with the actual image, but going back to the underlying tissue properties. But we know that even these values are not 100% stable or over different scanner platforms and different field strengths. So I think currently we are still at a stage, if we want to follow up an individual patient, we should try to stay as close as possible with the scanner settings and scanner platform over time, because you will always get some different results if you change this. From my experience, different scanners are not so much of a problem, but different scanner platforms and different field strengths. So in our hospital, for example, we had for some time two similar Siemens scanners, the same platform. And if you compared the same subject with these two, we got comparable results actually. But if you changed to a 3 Tesla scanner from the 1.5, there were totally different results. And I think this is still a technical problem there. And it's not so easy to tackle. So I think we're still at a stage where you should stick at least for the same subject with the same scanner and sequence if possible. And I'm not really sure how fast we can find a solution for this, because it's really, really technical, challenging to model this and to find a solution. Also, with now increasingly being used AI solutions to increase scanning speed, we really don't know how these will affect gray-white matter contrast, and if these might affect cortical volume measurements. There's no data out there yet. So I currently suggest not to use these kind of options for volumetric results, because we just don't know yet. It might work, but we don't know.
I think we are on time, Benjamin, but I do want to ask, I think, one more question we can fit in. Now, this is about an anonymous attendee. It says, are there any unique challenges or considerations when building AI to help with early detection of Alzheimer's or dementia versus building AI for stroke or hemorrhage?
Unique. I think unique for dementia is, well, in principle, you always have the same problems. The biggest problem is to get good data. And we also did a lot of research, and we had a look at many different data sets out there. And from our experience, the biggest problem is the data quality in many cases, because we've seen diagnosis change over time for the same subject. So we've seen data sets where suddenly models didn't work at all, and where we believe there must be some mistakes in the metadata. We cannot find any other explanation. And usually, if the metadata are well documented, it works well. And other databases where the documentation is less or is not as good as in others, it's always the same. Then you always have the feeling, well, there might be a glitch in the data. Still, this is the only data we have, and it's also a problem to get enough data from different vendors. So we have data from the large 3 vendors out there for MR machines, but there are also other companies and also low field strength scanners. And if you want to create a solution that works with every MR scanner out there, you have a really hard time getting enough data and getting the metadata out there. And this is, I think, still the biggest challenge for AI in medical imaging at all, to get good annotated data, not only hand segmentations. I think we don't need those for a lot of stuff, but to get real good clinical diagnosis. For example, in many data sets, the Alzheimer's diagnosis is based on the neuropsychological testing. And nowadays, they will ask for amyloid. So in many new data sets, we have amyloid PET, which is very good, which helps a lot. But in older data sets, well, you just have to trust, and there might be 5% FTDs in there. We just don't know.
Yeah, well, with that, unfortunately, we are on time, and I'm hoping my marketing team is listening in, because I think we will need a repeat webinar with Benjamin, because
We
I
need
have
to make
actually
this
so
longer.
many questions, in any of the webinars that I've hosted. But to all those who have posted questions, be rest assured that we will answer these. Recording of this webinar will also be available on our YouTube channel. And we'll see you next week, same time, same place. Benjamin, thank you so much for making the time and doing this with us. I think this was a very informative session, and we'll probably need more time with you in the near future.
Thank you very much for having me here.
Bye.
Bye.